purpose of the seminar series is to present world-class advancements in biomedical research and its direct applications to clinical practice. Today's speaker is Dr. Holmes Morton. He will present his talk, Biomarkers from Diagnosis to Novel Treatment. Dr. Morton's research focuses on identifying and treating genetic disorders in Amish and Mennonite communities, and he is also the co-founder of the Clinic for Special Children in Lancaster and Kish Valley, PA, along with his wife, Caroline. Some of Dr. Morton's honors include being featured in Time Magazine's Heroes of Medicine, recipient of the Smithsonian Award for Innovations in Technology, Community Service Award from the American Red Cross Overseas Association, the Schweitzer Prize for Humanitarianism, and the MacArthur Foundation Fellowship, along with numerous honorary doctorate degrees. Please join me in welcoming Dr. Holmes Morton.
Thank you. Is this mic'd here? Can you hear back there okay? So yes, we teach a course actually have for years, and when I say we, I mean Kevin Strauss and Eric Pufferberger and I, called Plain People in Modern Medicine. Small populations, small science. So much of modern medicine, modern science has to do with big studies, big pharma, big genetics, genomics. And what we've tried to do is show that by working with individuals with rare diseases, you can gain insight into the genetic and metabolic basis of disorders. And we work with Amish and Mennonite people not because they're different from us, but because they are us. So whatever we learn about taking care of maybe sort of urine disease or Cherokee Aciduria or Cherokee Aciduria in the populations that live not far away from you, we are learning about European variants of these disorders. And if I see a child from Texas with the Cherokee Aciduria type 1, it is 25% of the time that child carries one allele for glutarylchoate dehydrogenase that is the so-called Amish variant. Same thing with maple syrup urine disease or propionic acidemia. These mutations are markers for migrations of populations, and they determine genetic disease in all populations. And we shouldn't think that people who live in Lancaster County have to be of Amish or Mennonite background or strange or unique. They represent a genomic survey of European diseases that just came to this country 300 years ago. So, and ultimately, medicine is care of the individual, of course. It is local care. And, when I first put this nice timber frame building out in the middle of an Amish farm, people thought I was crazy. But it really has worked out to be a place where you can practice medicine and integrate genetics into medicine in a seamless way. And it's allowed us to generate a lot of insight. And that's what we're really talking about today, is insight into metabolic diseases. Now, to put it in perspective, when I was at Children's Hospital of Philadelphia as a fellow, a group of physicians, there were 6 physicians there who specialized in metabolic diseases. And they only followed 157 patients, which would never make it in today's economics, but that's the way it was. And only 10 of those patients were from these famous populations that lived just 40 miles away. There were only 10 children with a recessive disorder called maple syrup urine disease. Anybody heard that? No. You know how to diagnose it? Put a Q-tip in the air and smell it. The cerumen smells like maple syrup. It is the odor of maple syrup. It's inside. So anyway, we followed these 10 patients with maple syrup urine disease. And the first Amish patient I saw was 2 years into my fellowship. And that was an Amish child with Cherokee Aciduria type 1, which we thought was very rare. And I'll tell you some of the history of that as I go along, but today we have 3 pediatricians who work in Lancaster County, just 40 miles away from Children's Hospital of Philadelphia. we followed over 2,600 children with 180 different recessive disorders that were not being seen by the major medical centers in Philadelphia. So I always ask in the public health spirit, were these populations being underserved? Yes. And they were by that time famous populations. So Victor McCusick, who ultimately went on to be physician in chief at Johns Hopkins and was the father of the Human Genome Project, made his career working with the same families that we work with in Langston County. And he was introduced into those populations by John A. Hostetler. Another book, Amish Society. John grew up over here in Big Valley. Was a little Amish boy. His family was excommunicated actually from the church, and he went on to college at Goshen College, and then ultimately did a PhD in sociology at Penn State. And his book, Amish Society, is still one of the best accountings from a sociological point of view of these cultures. And it was John Hostetler that introduced Victor McCusick into the Amish and Mennonite populations in Langston County and ultimately all over North America. And that really is what built McCusick's career. So the study of these populations is historically important in the history of medicine and genetics. And what we tried to do, my wife and I tried to do years ago when our NIH funding didn't come through to study with Cherokee Aciduria, we just decided to set up a practice in Langston County that happened to be a nonprofit organization to allow me to take care of some of these patients as a pediatrician. And my feeling was that by working with them, we would gain insight into their diseases. And you got 180 to choose from. They're not all biochemical disorders, but I thought for this talk this morning, I would just talk about several of the biochemical disorders that have provided us with particular insight into how the biochemical disorders affect growth and development and function of the brain, and how you use that as a clinician to think about developing new therapies that are based upon insight. And again, one thing to always keep in mind, anything that has bad medical consequence is in some sense, by definition, biologically important. So understanding the fundamentals of any of these rare disorders, as William Harvey said in 60 to 57, gives us insight into biology and medicine that's really important. I use this quote a lot. Now, when you got out your Stryer biochemical book or Linenger or whatever you use nowadays, this is kind of a concept of maple syrup therapeutics. And it's, of course, the branched chain keto acid dehydrogenase defect. This is these 3 branched chain amino acids that are being deaminated, and the ammonia group goes on to glutamate, and then the alpha keto acid accumulates here. This provides me with no insight. You memorize this stuff. This is a little more sophisticated look at what this complex enzyme looks like. This refers to a little boy in Honduras that I'll show you a picture of later. He has a milder variant of the disease, and you got all these really nice pictures of the protein structure of this enzyme, and we talk about what regulates the activity and so on. But again, memorizing that picture, whatever that means, really does not help me very much understand this disease. There was a time when Stanberry's Metabolic Bases of Inherited Disease was full of efforts to figure out the protein structure of these enzymes and characterize the enzymes in great detail. So at least 50 or 60 of the text of the book is filled up with enzymology. And yet, when I work as a clinician and take care of these children, that's not helpful to me. And I have to put the mutation up here for the for the Mennonite variant of maple syrup disease, because I just have trouble remembering it. It's not that useful. It's useful diagnostically. We use it as a diagnostic tool. We get a sample of cord blood in our lab. We can do real-time PCR using a light scanner. So from the time we get a cord blood or draw blood on a patient. It takes about 2 hours to do this diagnostic test to show that the baby is homozygous for that known mutation. We charge $35 to do that. We're actually making money on that. If you did that down at Penn or UPMC, it cost you $4,000, but it's really pretty cheap stuff. But again, what we're trying to understand is why does this disease cause such trouble? Now, when I was a fellow, about half the children with maple syrup disease died before they were 5 years of age of cerebral edema. So they would become ill with ordinary ear infections, vomiting, diarrhea, viruses, RSV. And then they would come into the emergency room at either St. Christopher's Hospital or CHOP, usually in a coma, and then somebody would give them some IV fluids, and 12 hours later they'd be dead. So part of what we had to really understand was what the relationship was between infection and metabolic illness, how to control that. And not surprising to you, part of the way you control infection in children who are vulnerable to these kind of metabolic decompensations is to actually have a medical practice where you treat infections early on, where you prevent infections with immunizations. So, people ask me, well, how do you prevent metabolic crisis and all these disorders? Well, part of the answer to that is make sure that people get their immunizations for whooping cough or H flu or pneumococcus or any of these bad illnesses that provoke a catabolic response to illness. So your metabolism switches from being anabolic, which means you're growing, to being in the catabolic state, which means that you're breaking down endogenous protein to help activate the immune system to build immune globulins and proliferate cells and so on. And part of the strategy for taking care of children with these diseases is to realize that the major cause for admission to hospital, and this is between 1990 and 2012, we're up over 300 hospitalizations now, and you go through and ask what caused these severe illnesses, for everything from just having SCIDs, severe combined immune deficiency, to ordinary gastroenteritis. Rotavirus is the worst. Rototec prevents that. Strep pharyngitis, ear infection, very common. And then we have kids who get appendicitis and have cholecystitis and get gallstones. Or, this little boy fractured his femur. And just the stress of that kind of injury will provoke a metabolic crisis. You don't have to have great insight into the biochemical basis of these illnesses to realize that part of the strategy for taking care of children would be to allow them to have access to care where these things are taken care of not only in a timely way, but are taken care of by people who also understand metabolic disease. And I'll tell you that probably one of the most important things about having that clinic in Jake Stoltzfus's field is that it's easy access to care. And we can make a decision about how severe the metabolic illness is and whether we have to take a child off the hospital or not. We do your blood leucine level while you wait. It's probably the only place in the world you can get that done. It takes us about 20 minutes to run an amino acid profile through an HPLC and assess the child metabolically. And then we now know how to sort of change the dietary, nutritional control of these diseases, and we often can prevent hospitalizations. And I'll tell you about the cerebral edema as I go along. But, it is surprising to people sometimes that just knowing this kind of stuff helps you design a healthcare system that's more effective in preventing severe illnesses from a whole host of inherited metabolic diseases. That's insight. You can't get that from a molecular, knowing what the mutation is, or even knowing what the enzymology is. You can understand why the body reacts to infection that way. But if you're really trying to get insight into the natural history of the disease, knowing this helps you anticipate the problems you're going to have. Now, this is a graph of the branched chain amino acid from a baby who comes into the hospital with MSUD. This is the leucine level that's normally 131, and here it's almost 4,000. This child would be in coma. Leucine is very toxic to the nervous system. Isoleucine and valine are also involved in that, but they're not toxic. And that turned out to be very important in terms of insight about the disease too. And what we've got to do is get the leucine level back down to control, to near the normal range. And so how do we do that? And what's the goal? What's the strategy here? We don't like to use dialysis. It's hard to do dialysis in a newborn to get rid of leucine. You can do it, but you've really got to be good at vascular access and stuff. This is all done nutritionally. And essentially what we're doing is capturing metabolism and forcing the baby from the catabolic state, where you're breaking down endogenous protein, into the anabolic state. And I'll tell you what the variables are in a minute, but basically, as a child gains weight, about 12% of that weight is new protein. And of that new protein, 10% of that weight in humans is leucine. So you're reincorporating leucine into protein. This is a very strict stoichiometric relationship. You can calculate what the total body burden of leucine is by using 0.6 liters per kilogram, and then you can figure out the rate at which this baby is making protein just by looking at the consumption of that leucine. And it took actually a number of years when I first went to Lancaster County to sort of work out these variables. But these are the variables. So anytime I write orders, as I did last weekend on a child from Big Valley, or an adult from Big Valley who had a MRSA infection of the knee, was extremely ill, came in, and we used this MSUD hyperalimentation solution, which is just an IV solution. And these are the goals. Glucose infusion rates. We have to give so much of the amino acid mixture, which helps support protein synthesis. So these are amino acids that are enriched in the essential amino acid, particularly the L1 neutral amino acid transporters I'll talk about in a minute. 2 to 3 grams per kilogram per day of this amino acid mixture, and then insulin to help induce protein synthesis. We need to prevent isoleucine and valine deficiency, so we give 60 to 120 milligrams per kilogram per day. And then we'll have to deal with the sodium and potassium. And those are the parameters. That's what you use. You sit down, and that's the way you induce an anabolism, and that's the way you contain it. Now, every person who is in an intensive care unit with MRSA, or every patient goes in an intensive care unit because of a car accident, broken femur, burn, has the same problem. You are catabolic. When you are ill like that, you die of catabolism. You consume yourself. And the surgeons will tell you, well, we just give a little bit of D10 and that takes care of catabolism. And that's nonsense. Every patient needs this kind of nutritional intervention to prevent extreme catabolism in an ICU. And most of them don't get it. One of my teachers in Boston is named Doug Wilmore. He was a burn surgeon. He spent his whole career studying nitrogen turnover in patients who had had burns or severe accidents or had bone marrow transplants. So he worked at a big hospital in Boston called the Brigham. And Doug loved to talk about maple syrup urine disease because when he did those studies, he had to do these really complicated nitrogen balance studies where you collect stool and urine and try to figure out the turnover of protein, whether you're winning or losing the race. In MSUD, leucine is your marker. If they are catabolic, the leucine level is going up, and if they're anabolic, it's going down. So we can do all these studies, learn all this stuff about the care of people with acute illness just by using this unique metabolic disease that provided us with a good marker, which is the leucine. We're studying this. And, I mentioned when I started that when I was a child, about half these children died by the time they were 5 years of age in cerebral edema, and I'll talk about that in a minute. But it was being able to rescue them from these kind of illnesses, ordinary illnesses, that allowed us to change the natural history of that disease. We've had over 300 admissions to our little community hospital in Lancaster for this kind of metabolic crisis, and we've never had a death from cerebral edema. We had one bad stroke. Did we learn something useful? Yeah. And now this is another thing. This baby has severe maple syrup urine disease. I think this was in Stansberry's book. He described maple syrup urine disease, had a picture of this in his original paper. This child is stiff. Most physicians think the child's having seizures. They're not really having seizures. What they're having is a deficiency of tyrosine. So tyrosine makes dopamine, and if you are dopamine depleted, you're stiff, just like in Parkinson's disease. So what this graph is showing us is a complete new insight into the relationship between intoxication with maple syrup urine disease and function of the brain. And the insight really became much more clear when Kevin Strauss, who works at the clinic now, came down from Harvard Medical School, and he brought with him the descriptions of these LAT1 neutral amino acid transporters that had been described by Howard Christensen in the 50s. And this is basically a protein transport system that gets 8 amino acids into the brain. And that transport system is easily saturated, so the amino acids are actually in competition with each other. And what this illustrates is when the leucine level is very high, it blocks out the uptake of all these other amino acids. And not only are they leucine toxic, but their nervous system is not functioning well because the uptake of all these neurotropic amino acids is restricted by the imbalance in the transport of the LAT1 transport. And Christensen described that in the 50s. Quentin Smith, who really is credited with working out the equations that we use all the time, worked at National Institutes of Health in the 80s. And by 89, he had a pretty good description of the transporter, the human transporter. And Strauss came down from Harvard and had this little spreadsheet that he'd set up on an Excel spreadsheet so that you could just plug in the value of any one of these amino acids and see how it affected the transport of the other amino acids. So I started using that in 1996 to optimize the amino acid mixture in the IV solutions that we were using, and ultimately we used it to design a formula for MSUD, which is now used worldwide, improve the hyperalimentation solution, and then we went on to design other formulas using the same principles. At one time, we had Howard Christensen, who was in his 80s, and Quentin Smith, who had just finished his work at NIH at the clinic. And, I showed Quentin Smith an example of an amino acid profile like that. He said, well, I guess you don't really have to be Quentin Smith to see that's a problem. And talking to Christensen about his work back in the 50s was actually very interesting. He said, he was really appreciative that we were actually making use of something that he discovered in the 50s. He was nominated for the Nobel Prize for that work, but didn't get it. And died not too long ago. So this is just a graph showing this concept of competitive transport of these amino acids into the brain. The brain of a child who has been chronically deprived of those amino acids looks like this, and this is the dendritic branching along the cortical surface of the brain. This is actually a depleted dendritic branching due to malnourishment. This is the malnourishment, or this is the cortex, the dendritic branching within the cortex of a child with kwashiorkor. Worldwide, the most common cause of mental retardation is kwashiorkor. In MSUD, the most common cause of this picture of mental retardation is over-restriction of valine. I made a comment earlier that valine is not toxic. So you can give very high levels of valine, much higher than we see with leucine, and it has no effect. But if you deprive the brain of valine, which is an essential amino acid, you get bad outcomes. So it turned out, when we looked at the data, if you ask what determines cognitive outcome in patients with MSUD, the valine to leucine ratio is more important than the average level of leucine over the lifetime of the patient. In all of you in the room, I went around and sampled your blood and calculated the valine to leucine ratio. It's 2 to 1. And that's the way it must be for enough valine to get the brain to supply your brain. So, again, one of the early things that we learned in Lancaster County was that children were chronically valine deficient. This little girl, amazingly enough, came from Amsterdam. She was sent to Lancaster by her insurance company because they couldn't get her out of the hospital. And she had lost most of her hair. She had this terrible amino acid deficiency appearing face with a lot of rashes. She wouldn't eat. She was anorectic. She'd been anemic. They had to transfuse her. They couldn't get her out of the hospital. And when she came to the hospital, I did an amino acid profile, and this is what her valine level looked like, and it had been that way for 5 months. And this collection of features, arrested head growth, hypomyelination, dermatitis, hair loss, all this is the syndrome of essential amino acid deficiency. So all I did was give her about 100 milligrams per kilogram of valine, which caused her blood levels to go up higher than normal, but I didn't care. I just want to make sure she got plenty. And you can see the effect it had on her head growth. Well, head growth is brain growth. So she actually recovered. She's almost 20 years old now. Has a little bit of attention deficit disorder, but she went to school with other children. She drives a car, runs around kids her age. So we were able to kind of rescue her. And all I really did was give her Bailey, reestablish the balance in the uptake of amino acids in the nervous system. We pulled that feeding tube out the next day. She's never been hospitalized again. She actually has an unusual variant. She has a milder variant of MSUD. It's very easy to treat. You guys probably looked at a lot of MRIs, right? So this is an MRI of the brain. And normally this would be all dark structure in here. There's a ribbon of white around the surface of this brain, the cortical areas. That's all water, that's all edema. And when this brain swells beyond 5% of its baseline value, then it begins to push along the base of the skull down this area, and they herniate and they die. They die of strokes. It crushes the blood vessels that come up through the posterior part of the brain, and then they get poor perfusion of the brain, and they die of that. And it actually, I'll never forget, when I was a fellow, there were several patients who died of cerebral edema, but we really didn't know anything about it. And the first patient I had at the hospital in Lancaster who arrested from cerebral edema was a little girl about 4 years of age, and I admitted her to the hospital just to keep her from getting sick, which in retrospect wasn't that smart. And I noticed that her leucine levels they were barely elevated. They had gone down over the time, the 12 hours she was in the hospital, and then she arrested despite the fact that I was controlling her metabolically. And when I looked at her laboratory values, I noticed that her serum sodium, which determines your osmolarity, right? So cells need to have osmotic balance. Membranes are permeable to water. So when you increase the osmolarity in one place, water shifts, and the osmolarity in the extracellular space goes up in the intracellular space, and you reestablish an equilibrium. And essentially what it worked out to be was that as people get sick with maple syrup urine disease and become catabolic, their serum osmolality goes up. And we measured that in the hospital. It would go up from 280, which is what ours is, up to about 300 or 315. And the brain feels a threat of being dehydrated, so it synthesizes some osmoles inside the neurons to maintain that osmotic balance, to keep it from becoming dehydrated, to keep the high osmolarity in the blood from pulling water out of the brain and causing it to shrink. And then we put these IVs in them and have a lot of water in them. The osmolarity, the adaptive osmolarity in the brain doesn't go down immediately, but we as doctors can drop the serum sodium very rapidly, which decreases the osmolarity in blood and shifts water into the brain. And that number, 140 to 132, is exactly calculated to be the amount of water that will increase the brain volume 5%. At 5%, you herniate. So when I looked at the literature, there were all kinds of case reports of people died of cerebral edema, and they all died when their sodium got to 132. It wasn't a metabolic problem, it was a problem of ion regulation and osmolarity. So now we have what's called the Morton cocktail at Lancaster General. The boy I had in the hospital this past weekend got 3 doses of this stuff. It's a 0.5 milligram per kilogram of mannitol, which is a sugar that increases your osmolarity, pulls water out of the brain. Lasix blocks the ability of the kidney to retain water, so it counters the effect of vasopressin. And then after we've gotten a big diuresis, pulled some water out of the brain and got it through the kidney, then we give back hypertonic saline to maintain normal blood sodium. And so throughout the hospitalization, this young man got 3 doses of that. And you usually have to give it to kind of wake up and start watching television, whatever they're doing. I mean, it really affects them remarkably in terms of their neurologic problem, but has prevented this progressive cerebral edema and deaths from cerebral edema. Once the leucine level normalizes, once the osmolarity normalizes, then that propensity to have cerebral edema goes away. It's insight. What did that have to do with the molecular lesion or the enzymology? It's just kind of basic biology, really. This little girl has maple syrup urine disease, and this story is really about a cousin of hers. So our oldest patient was diagnosed in 1967, so she's almost 50 years old. She was at St. Christopher's Hospital in Philadelphia for months. She was the first of the Mennonite children to survive. She didn't regain her birth weight for 16 weeks, which is awful. And she is spastic, fully retired, fully dependent upon others in care. Her niece was discharged in the low-risk program at Ephrata Hospital, came to the clinic. We diagnosed maple syrup urine disease, just drawn a blood sample, ran it through the amino acid analyzer, and said, yes, she has maple syrup urine disease. Here's some formula, I'll come out in a couple days and draw blood. And so she went home and was taking care of the newborn at home. She has never been hospitalized, grown up normally. And this was all described in a paper in 2002, that this whole strategy of how you manage maple syrup urine disease in the newborn, how you rescue kids from crisis, how you manage the cerebral edema was worked out between 1989 and 2002. In 1997, we had an unusual experience, another one of the insightful experiences. There was a Mennonite girl who was 8 years of age who was taking vitamin A. Somebody had told her mother that if she gave her big doses of vitamin A when she had a cold, it would boost her immune system, whatever that means. So she had liver failure. She went into liver failure from vitamin A. Don't ever take too much vitamin A. It's one of the few vitamins that actually kill you. So she went into liver failure, which was a nightmare in terms of taking care of her MSUD. And finally I said to the parents, I said, we just can't keep rescuing her. We're either going to have to do a liver transplant, or we're going to have to let her go. Well, now this little girl, the only unfortunate thing about this picture is she can now eat that rabbit. So she raises rabbits. She used not to be able to eat until she had a liver transplant. From that liver transplant in 1997, we learned that transplanting the liver protects the brain from MSUD. So by the time Catherine came out of the operating room, her MSUD was gone. She could eat pizza, she could eat steak, she could eat whatever she wants to. And it gave us great insight into the fact that the liver regulates the plasma amino acid profile and regulates the uptake of amino acids into the brain. So if you do a liver transplant, basically you have cured this disease. The same thing would be true for PKU, which is not as dangerous as MSUD, but it's a miserable disease. So we've now done, with Children's Hospital of Pittsburgh, 69 liver transplants, all successful. No retransplants, no deaths. Remarkable. When I was a resident, the mortality for liver transplant was still about 50%. By the time you went to get a liver transplant, you were nearly gone. And about half the time they could rescue you, and half the time they can't. What makes the surgeons in Pittsburgh nervous is taking a healthy child like this and doing an elective liver transplant. But what they learned was that healthy children tolerate liver transplants much better than people who are on death's door. So our outcomes have been remarkably good. Insight, that was again another example of a disaster, which was that girl taking vitamin A, but by being involved with her care and taking her through a liver transplant, we learned something fundamental about this disease and its ability to control MSUD by the liver transplant. This is just a scatter of leucine levels in a child who's being medically treated. Not so good. I mean, these are illnesses and too much leucine and non-compliance, all those things that make it difficult to control leucine. And after the transplant, this is what happened to leucine levels. And at this point, the patient is eating 10 times as much protein as she could eat here. Regulation. This little boy came up from Honduras. Now, he also had a milder variant of MSUD. He has what really is kwashiorkor. He has really severe essential amino acid deficiency. They were trying to treat him with rice water and didn't have MSUD formula, didn't have the supplies you need to take care of it. And so, came up to Lancaster. This is what happened to his growth. This is head growth. This is his linear growth and weight gain here, but this is brain growth. When you treat the disease, they actually are very responsive. So that's that little boy about 2 to 3 weeks after coming to Lancaster County. So this stuff I'm talking about is not theoretical. It's not just a little bit important. It's actually insight into the biology of this disease. And here's a sad truth that I remind everybody of. We've done a lot of liver transplants on children from Brazil and India and places like that as part of this program. About 30 of those cases are from the Mennonite community, and the rest come from everywhere, Saudi Arabia to the Netherlands to India, the Philippines, and other places where medical care is not so good. And if we look at the IQ, EQ, intelligence and developmental scales, a lot of these patients who are coming from other places have low IQs. That's brain deprivation during a critical time of brain development. These dots like these are ours. The dark dots are patients from Lancaster County who have been transplanted at the time of this paper was reported, which is 2000. But the message is that if we're going to do liver transplants, we must start working with these children before they have cognitive impairment and poor brain growth, or our outcomes are not so good. Now, we do transplants in children who are disabled by this disease because it improves their quality of life. And there was, you can imagine, a big ethical argument about that. I want to move on, but let me just tell you one more thing about liver transplants, which is another one of those insights into biology. The MSUD livers are fine. They lack one enzyme. Otherwise, these are normal livers. So when we do a transplant, we take the MSUD liver and we give it to another child who has liver failure for another reason. And if we have an 8-year-old and we have 2 babies who need to be transplanted, we split the liver and give them to 2 children. And if you have a parent who wants to donate the left lobe of their liver, you can do that, put it into a child with MSUD, take that liver and split it and give it to 2 children, and you have a gain in the system. So the reason, well, why do you think? Why does it matter that we put a liver that's deficient in branched-chain keto acid dehydrogenase in other children? It doesn't matter because about 90% of the enzyme activity is also in kidney and muscle and brain and other places. So the fact that the liver has a block in that enzymatic pathway affects the plasma amino acid profile a little bit, and that's kind of another lecture. But it is not of great biological significance. So we do as many of these domino transplants as we can, but you can imagine they have to have 3 surgical teams active at the same time to do one of these transplants. And it's a big deal. Now, the Cherokee Aciduria. You've heard of MSUD. Have you ever heard of the Cherokee Aciduria? Have you ever heard of that? Yeah. Back in 1988, when I went to Lancaster County, not many people had it. It was thought to be a very rare disease. None of us who were working at CHOP had ever seen a child with Cherokee Aciduria. I diagnosed a case in a child of Amish background, and knowing something about the history of that community, I just drove out to Lancaster County to see him. And I asked his parents if they knew about other children like Danny, and they said, oh yeah, we have a chain letter. This is the cerebral palsy count. And as they say, the rest is history. That trip sort of changed my life and a lot of lives. So just remember this girl. She's being examined. That's a photograph by a famous photographer named Max Ornsner or something like that. It was done at Time magazine. She's the first non-Amish child diagnosed with Cherokee Aciduria with the newborn screening program in Pennsylvania. That was about 1997. And I'll come back to her in a minute. This is one of those famous pedigrees. So this man was named Lapp, and his wife's name, you don't know before she was married, but they were Lapps. And all the children that I diagnosed in the summer of 1988 were descendants of these two couples. The Cherokee Aciduria occurs in the Amish population about 1 in 400 births. It's about 2 new cases a year. Not terribly common as problems go. In the general population, it's more like 1 in 10,000, 1 in 20,000. It's present in the general population. As I said, if you're from Texas and have the Cherokee Aciduria, about 20% of the time, 25% of the time, you have an Amish mutation, at least one allele that's affected. This is what the Cherokee Aciduria looked like. And who would have thought you could prevent that? Well, nobody did. Steve Goodman, who described this disease in 1976, said, "Morton, you're crazy. The brains are abnormal when these children are born. You can't rescue this disease." But when we got to history, I was going around Lancaster County collecting urine samples, running through a GC mass spec that is now set up upstairs in the school. And we were looking for infants with the Cherokee Aciduria. And my feeling was that, yes, this damage is irreversible. So this is a stroke. And one of the things that will surprise you is that she is quite smart. She speaks 2 languages, understands 2 languages. She gets all your jokes in English, so that means she can process idioms and subtleties of syntax and so on, and understand a joke. She is cognitively intact. This all arises from degeneration of the basal ganglia, and the part of the basal ganglia called the putamen, and she has dystonia. She's not spastic. She doesn't have cerebral palsy like hyperspasticity. She has dysregulation of tone, dystonia, co-contraction of opposing muscle groups, is the way the neurologist described that. And if you look at an MRI of her brain, there's almost a surgical lesion that has destroyed part of the brain. And the most interesting thing about this disease in the first days I was talking to families about it was that the families could always tell you the day and the time of day when that happened. And before that stroke happened, these kids were normal. So they were either beginning to sit up or learn to sit up, they could cruise, they were acquiring language. This was not cerebral palsy in the sense that you were hypoxic when you were born. And it was that insight, just being able to say, this only happens during an episodic illness, and it's almost always infectious. So Ruthie had chickenpox when she got her disaster. And just by listening to the natural history of the disease, the insight was that this would likely be preventable if we could figure out what the event was that triggered the stroke. And I said a lot of things about the Cherokee Aciduria in the early days, but the only really smart thing I ever said about it was that we will never learn this disease unless we test for this and find asymptomatic infants and then try to protect them from injury. And that was smart. So I started screening for this in Lancaster County in our small lab in December of 1989. The first 6 samples I ran through the machine, the 6th sample was positive for this disorder. And we had an Amish woman work for us who talked the family into cooperating with me about this new therapy, which really was based upon a model that subsequently was proven to be wrong, but it worked. So this girl was the first child diagnosed. She's here maybe 10 or 12 years of age. She's now married, has a child of her own. We know that she can have children, and the butyric acid that floats around in her blood does affect the baby. Her husband is not a carrier. We know what the gene mutation is, we can tell that. Her sister is also affected. She got married last fall. This little boy is non-Amish. He had a crisis at about a year of age, had a terrible stroke, and it is because of him that we have newborn screening, not only in Lancaster County, but statewide. So 152,000 children here are screened for this disease. In the United States, 4.2 million children are screened for this. It's considered one of the most treatable disorders that can be picked up by newborn screening. And it's picked up all over the world. Very common in India, very common in Germany. I live not in Ireland. Saw a lot of Irish patients with Cherokee Aciduria, and George Hoffman in Germany did, and they both believed that I did this to be a treatable disease. So that interest and that expansion of knowledge about this wasn't just from the clinic, but it really occurred throughout the world. So now this is tested for. And in the early days, when these children were born, our success rate in preventing that was about 2/3. Now, we really, when we see a new child with this, we expect it to be good outcome. So what's the insight? How did we get from 95% disability to 95% plus success? What did we learn? Well, there are a couple of interesting things. This is the biochemical pathway. This is glutaraldehyde dehydrogenase, which is the disorder. And what I realized when I was doing the early screening for the Cherokee Aciduria was it was unfair, but there were actually two kinds of Cherokee Aciduria in the Amish population. There was a benign form of it, and I would sometimes diagnose 4 or 5 people in a family who had high levels of glutaric acid in the urine and blood, but they weren't sick. They didn't have strokes. And then there was the type 1 glutaric aciduria, which old Ruthie had, that caused these strokes. And when we started doing newborn screening using filter papers, the PKU test, they're very old, we stopped picking up this disorder, the mild form of glutaric aciduria, because they don't make glutarylcarnitine. Now that was an insight, but it took a while before we got there. We had a high school student from Effort High School who wanted to do a science fair project, and Eric Puffenberg gave him the job of finding out what that other defect was, of doing what's called a mapping study. And it was very easy to do. We used something called microarrays. We got several people together who were affected by this mild form of glutaric aciduria. We looked for shared regions in their genome. And then there was a candidate gene that Eric Sherman went in and sequenced, and it turned out to be glutarylcholine synthetase. So glutaric acid is made from the degradation of lysine and tryptophan. The glutaric acid is free in the mitochondrial matrix, and it's not activated to CoA. There's not a toxicity. So we learned that it's really the glutarylcholine compound itself that is toxic, and the glutarylcholine forms this 3-hydroxyglutaric acid by interacting with succinyl-CoA dehydrogenase. Now you all remember that from your biochemistry, right? Part of the citric acid cycle, one of those critical steps in the citric acid cycle. That is step 2 of the electron transport system. And another little insight into what it means to inhibit that enzyme system came from kids in China who eat unrefined sugar cane. And there's a bacteria or a fungus that grows on sugar cane that produces something called 3-nitropropionic acid. And 3-nitropropionic acid is a selective and potent inhibitor of succinyl-CoA dehydrogenase. And it's now used as a model for Huntington's disease, glutaric aciduria, and propionic acidemia. But it's the interaction between glutarylcholine and succinyl-CoA dehydrogenase that we think causes these strokes. And actually, I was going to talk about propionic acidemia, I won't get to it. But propionic acidemia does the same thing. It interacts with succinyl-CoA dehydrogenase, forms 3-hydroxypropionate. Glutarylcholine interacts with this, forms 3-hydroxyglutarate, and these are dead-end metabolites. And probably it's the interaction between these compounds with succinyl-CoA that interferes with energy production in the citric acid cycle and results in strokes. The insight, though, really came from some Indians in Manitoba, Canada, who have an untreatable form of glutaric aciduria. They all die from this disease. It's a very severe form, and they are what we call low excretors. So there's not much glutaric acid in the urine. And so Cheryl Greenberg, who takes care of that group of patients, did an autopsy of one, and George Hoffman's group in Germany measured the glutaric acid level in the brain. and found that the concentration in the parenchyma of the brain itself is thousands of times higher than the spinal fluid or the blood. And when I heard that, I immediately said, we've been thinking about the disease completely wrong. This injury, this intoxication of the brain comes from the uptake of lysine into the brain, and then the degradation of lysine within the mitochondria in the brain itself. It's not enough to get glutaric acid from forming in the liver and the muscle, and it's not glutaric acid is forming there and then being transported into the brain. It is the brain is making it, and that completely changed the strategy for how we treat it. So this is a manual. That's the lesion right there. Everything else about this brain is normal. Cortical surface, normal. He doesn't even have any subarachnoid cysts. He uses it. What he has are the surgical lesions in the posterior lateral container. That is his injury. That's the stroke. And this region of the brain just happens to have a very high metabolic rate. So this is vulnerable whether you get carbon monoxide poisoning or you don't have good flow when you have heart surgery. This is part of the brain that rapidly degenerates. And what we then figured out was that just as there is a transport system for the LAT1 amino acid, dependent amino acid in Metabolic disease, there's a transport system called the CAT1 or Y plus system that gets lysine and arginine into the brain, lysine, arginine, and ornithine actually. And if you design a formula that is deficient in lysine and enriched in arginine, then you restrict the uptake of lysine in the brain. So here's brain lysine uptake. And we use the same set of equations for calculating this that we use in MSUD. And all these white dots show the decreased uptake of lysine in the nervous system. There's a corresponding decrease in glutaric acid excretion, not surprising. And what happened once we had this formula and began to treat the children more effectively was this. So this is when I first went to Lancashire County. This is in the mid-90s, early 2000s. And this was between 2006 and 2010. We had 12 patients treated prospectively and were spared this injury. I used to try to explain to people that the kind of learning that we do to gain insights into these things it's difficult. I just call it difficult learning. So if I give you a recording of Matt Hamlet's playing the Bach cello suites, and you listen to that, you're all very smart. You can tell me, a couple listenings about what suite that is, what key it's in, maybe whether it's a Seraphon or a prelude. So you learn that way. You learn to take tests. You learn to accumulate facts. But if I give you a cello and I give you a bow and say, learn to play that, that's different. That's a different kind of learning curve. It takes a lifetime. So most of the insights that we've gotten into these diseases are really from studying something over a long period of time. This paper was published June 30, 2011. That's 23 years after I first went to Lancashire County. That's took a long time to do that, and it was working under the circumstance that we were that made us directly responsible for taking care of these patients, that allowed us to have that insight. Yes, we use the literature, and we talk to people other places who study this disease, but ultimately it is being at the clinic, being at the place where patients need care, and integrating what we know about genetics and metabolism into day-to-day care that allowed us to get these insights. Now, I have several other examples for you, but time is running out. I just think that as you learn this stuff in biochemistry books, as you think about metabolism or anything you learn in biology, what you're really trying to do is get the kind of insights that I've talked about here. You're trying to get beyond just the schematics and say, this is glutaric aciduria because of the glutaric acid in the urine. You're really trying to understand how these systems, in some fundamental way, undermine some important factor in growth and development of the nervous system or whatever system you go through. And the biomarkers that you're looking for, the way you try to define the disease in terms of the variables that you can measure, has to be constrained by thinking about what those interacting systems are and how these systems make a difference. And I think you noticed that neither the mutation in maple syrup urine disease nor the mutation in glutaric aciduria, or even the enzymology gave us that insight. It was the biology. It was the biology and understanding intermediary metabolism and testing the hypothesis and actually taking care of patients that ultimately gave us the insight. So with that, I'll stop. I'll be around for the rest of the day. We'll do another talk. It might be quite different from this. And thank you for having me come out and talk to you.